Hi, I'm Dr. Valerie Masuda. I'm the palliative care physician in the Cowichan Valley. And this video is intended to show you how to access palliative care resources and how to access palliative care consultation as well. So, palliative care in the Cowichan Valley. So, what is palliative care? A lot of people don't actually understand what palliative care is. And when patients have a life-limiting diagnosis, from that time in their life to their death, we can have palliative care, and hospice care is actually the very end of life. So when we talk about palliative care, even if patients have treatments, we deliver palliative care from time of diagnosis of life-limiting illness all the way until death. So what do we offer? One is making sure a patient has good understanding of their life-limiting condition and what kind of treatments are available. We explore their beliefs as well as the patient's priorities and goals. We manage their symptoms, and we offer emotional, social, spiritual support as necessary. As their treatments may start becoming less effective, or if they're starting just to wind down and approach the end of their life, palliative care also moves in to manage symptoms, but also to provide nursing supports and care supports as necessary. And at the very end of life, we offer hospice care, which can be nursing care at home or in a residential facility, as well as the emotional and spiritual support. And of course, support of physical symptoms. And palliative care also is involved in bereavement care for those who are left behind. So as a primary care provider, this is how we support you. We support you with a very robust team. Home community care nursing is pivotal part of this team. They organize home care supports. They organize any equipment in the home. This can be anything from commodes to handrails, bath benches, shower chairs, or an electric bed, sometimes a commode, urinals, and other kinds of equipment. Home care supports are the people that we organize to come in and provide care for a patient. In the Cowichan Valley, we can provide up to 4 times a day supports where people will come in to help with personal care for an individual. This can support an individual living at home alone for a period of time, or it can support the family to care for a patient dying at home, all the way up into a home death. We also have access to physiotherapy, occupational therapy, and respiratory therapy through home and community care. We also have palliative social work who works to support patients for sometimes form filling, taxes, advanced care planning, health representation agreements with wills, estate planning. And we also have palliative care consultation services, which is a physician who provides a support to the primary care provider as well as the whole team. You as primary care provider will be connecting with home care nursing, and they will be communicating with you about concerns they may have for a patient. And then they will expect a response from you. You may access palliative care social work. Again, it's a two-way communication, and palliative care consultation services. And all these services also talk to each other. So your role as the primary care physician is really the communication with your patient, ensuring they have a good understanding of their illness. Communicating with your patient and you have a good understanding of their goals and priorities. Also ensuring their medical care is aligning with those goals and priorities. And this is so important because we as physicians, especially trained in this kind of Western medical model, tend to not hear patients where they are and what their priorities are. And we tend to place our own goals and priorities on their lives. We also expect you as a primary care physician to update their medical order for scope of treatment, but also to be able to change this as their needs and their priorities change with their condition. We expect the primary care physician to do basic symptom control, controlling nausea and vomiting, controlling constipation, managing pain. We also expect you to refer to home and community care services. We expect you to apply for palliative benefits, which is a provincial program that covers community support workers, home care nursing, and equipment, as well as medications for patients who are experiencing a palliative diagnosis. And we expect you to communicate with the home care nursing team. As part of your role as primary care physician, you'll be filling out the medical order for treatment forms, the expected death in the home form, end of life orders as needed. And we'll show you in this video how to do those things, how to complete them, as well as how to refer and when to refer for palliative consultation services, palliative social worker, emotional support, and hospice bed referrals as indicated. As you're the primary care physician, it's really important for you to learn how to have the serious conversation. Serious Conversation Guide was developed by Adriana Labs, which was started by Atul Gawande, who was the author of Being Mortal, which is an excellent book, and I'd recommend for anyone to read it. So what they did was looked at patients, what kind of information that patients wanted, what kind of language did patients also want around life-limiting illness. So the principles were that patients have goals and priorities that may not include living longer. And for you to learn about those empowers you to provide better care for the patients. You will not harm your patients by talking about end-of-life issues. In this community, people tend to be very open about acknowledging if they have life-limiting illness. And although there tends to be death fear in the community, people actually are appreciative when their primary care provider can give them good information about end-of-life care. Because of death anxiety in our culture, clinicians and patients are anxious about these kinds of discussions, but they ultimately want the truth about their prognosis. And it's important to be able to be flexible around these conversations. And really, we base that flexibility on the patient's need to know, want to know, and anxiety around the conversation. So give the patients an opportunity to express their fears and worries. It's therapeutic for them. So the way we approach the serious conversation is to set up the conversation. One, don't use a 10-minute appointment for this. This is setting up an end of the day, half-hour or more appointment. And so you want to also prepare the patient ahead of time. I'd like to bring you in to talk about something that showed up on your CT scan, or I'd like to talk to you a little bit about your diagnosis of cancer so that they're prepared, and also invite them to bring anybody else into the conversation, anybody that may act as a second set of ears or somebody who can support them emotionally. So you want to assess what their understanding is of their illness. You want to share prognosis, but it's really important not to give exact numbers because we don't know, and patients are often traumatized, whether you give a too short prognosis or too long prognosis. You want to explore key things like what are their worries and fears? What are their sources of strength? What are their critical abilities, the things that they feel are most important? For many, it's independence and mobility, for example. For some, it's being able to work and earn money. Also, the key topics around family. Who's in their family? Who's supporting them? It could be siblings, it could be children, it could be parents. And then what kind of trade-offs? What are they willing to do to buy themselves more time? And once you've had this conversation, it's important for you not to abandon your patient. Sometimes giving bad news, for example, a patient will say, I got this bad news, and then I felt like I was dropped. It's important to have the follow-ups. I will be with you through this serious disease, this life-limiting disease, and to document this conversation, the best place besides your own charting is in the ACP Goals of Care Power Form and Power Chart, so that everybody, nursing, hospital physicians, for example, know about the patient's goals of care, what their priorities and beliefs are, and a completed MOST that reflects those goals of care conversations. So this is patient-tested language, and I know a lot of physicians who actually laminate this card and pull it out of their desk before they have a serious conversation and just review it. You know, I'm hoping we can talk about where things are with your illness and where they may be going. Is that okay? What is your understanding of where you are with your illness? How much information about what is likely to lay ahead would you like from me? So those are really important questions, and these are patient-tested questions. Again, don't give a specific prognosis because it varies according to treatment, it varies according to patients' even social situation. The other thing is the wish, worry, wonder framework, where it's, I wish things were different, but this is what's happening. I worry that the results of your CT scan may be showing that this is cancer. I wonder if I can tell you what the next steps would be. There's a little example about that, but it's an easy way to kind of frame some of these serious conversations. So these are other communication support frameworks you may find interesting. If you have a patient who you suspect may be in their last 6 months to year of life or less, it is really important to fill out the BC Palliative Care Benefits form. This allows the patient to access, free of charge, any kind of support in the form of equipment or support workers, as well as medications to support them for their palliative diagnosis. And this is provided free of charge. It's very important to fill out this form completely, and it is so important. You'll see this on the red outline. If your patient is unable to sign because they can't make it into the office, as long as the patient understands that you are filling out the palliative benefits form, that in fact they have a life-limiting illness, fill this out and sign it on behalf of the patient. You see my signature up here as well as down there. So important because people are bedbound and yet they're told that they have to go in to sign this form. They do not need to come in and sign the form. However, I have heard of a patient who said they found out that they had a palliative diagnosis because the MOA phoned them and told them they had to come in to sign this form. This form should only be filled out if the patient is aware that they actually have a life-limiting illness and that you are filling the form out on their behalf. The second thing you need to know about is how to refer to palliative services. So when we talk about palliative services, this is the home and community care, nursing services, support services, equipment, physiotherapy, respiratory therapy, occupational therapy, and social work. So filling out this form and sending it to our central intake, the numbers are all on there, really important. The next one is the medical order for scope of treatment. This is a physician's order. It is not something for a patient to fill out on their own or with instructions. It is filled out after you've had the serious illness conversation with the patient and you understand their priorities and you've given them accurate and realistic outcomes expected with critical care interventions. Sometimes this is the way I'll approach it is patient who already has a serious life-limiting illness, you say, you know, people with these kinds of illness, with this kind of cancer, especially if it's metastatic, are at risk to die. And if you stop breathing or if your heart stopped, I would worry that putting you on machines would only cause suffering without any meaningful life. And I wonder what your thoughts are about that kind of intervention. What would be realistic for you? That's kind of the conversation, not sending them home with the MOST form and expecting to fill them out. If a patient you think is at risk to die within the next 3 months, The expected death in the home form is very important for those at risk to die. It expires every 3 months and needs to be renewed if your patients exceed what you felt was their life expectancy. But this form allows patients to die in their own home without having a nurse or physician to pronounce death. Just an hour after they stop breathing, the family can call the funeral home of their choice. They don't have to phone in an hour. They can have a cup of tea. They can invite the rest of the family to come and say goodbye to their loved one. Some funeral homes, they can call them and say, can I just have my loved one in the home still for another 8 hours or a day? And some people would like to wake their loved one in their own home for 3 days in some traditions. And there are opportunities for the funeral home to support that. The key is that the family just calls the funeral home. They do not call 911. So we do not need a coroner, police, or ambulance attendants to be involved at all. The important thing about this form is that this signature is only signed by the individual who's releasing the body to the funeral home. What the physician basically fills out is the patient's identification and then their own contact. The funeral home does not have to be filled out immediately. That can be filled out at the time that the family phones the funeral home or has made a decision on the funeral home. Next are the community patient care and prescription orders for end of life. These are orders and prescriptions. A copy sent to home care nursing is an order. The orders will include a nurse to insert the Foley to stop oral medications if the patient is unable to swallow. So these are really for patients imminently dying. You have an option for either if patients are opioid naive and they're not receiving regular opioids for morphine or hydromorphone. If a patient is already receiving regular opioids and it's to move to transdermal plus subcutaneous medications or just subcutaneous medications, it is up to you to decide what medication and the appropriate dosing. The other thing is for patients who are experiencing nausea or vomiting or experiencing terminal restlessness to fill this out. I have seen, unfortunately, physicians just checking all the boxes indiscriminately without proper dosing. You send a copy of these orders to the pharmacy along with the duplicate prescriptions as necessary. And these orders will be in place for the patient. The patient, often I get the patient's family to pick up all these medications, say a few weeks ahead of time to have in the home. And then home care nursing has the orders. And then when the patient becomes more imminent, when they are unable to swallow pills, they have everything available to them to start. It's not a crisis anymore. It's actually something that's planned. The family have a number for home care nursing. They phone the nurses come in and start the subcutaneous lines, and it works very, very well. For patients who have difficult to manage symptoms, who do not have a primary care provider, if they're very complicated family and community dynamics, and sometimes for our Indigenous patients, a referral form for palliative physician consultative services may be indicated. This is a consultative service. The palliative physicians do not have the capacity to take over all the patients dying in the Cowichan Valley. We really depend on the primary care physicians to support their patients for their end-of-life care. And certainly, if you require further training in this, the community does offer LEAP courses, which is Learning Essentials in Advanced Palliative Care. And this is generally free of charge. So if you're interested, please reach out and we can make sure that you are notified when the next LEAP course is available in the community. Quote is the admission referral for community hospice. So hospice care, again, is the very end of life care. But for those patients who can't die in their own home because they have a very frail family member or no family members that can take care of them for their end of life, they need to come into a residential hospice facility. So this is the form that you would fill out if your patients really were not able to die in their own home. if they don't have the appropriate supports. So we in the Cowichan Valley, the community raised $11 million and designed this facility and built this facility. It's a 10-bed, beautiful facility for patients. It's not a destination for end of life. We prefer that people stay at home for end of life care. Only in the circumstances where we can't provide end of life care in the home, we would look at moving them into hospice because they're only 10 beds. Those patients that are already in hospital, although hospice is certainly a better place for them to die, community patients get priority over patients that already have 24-hour care in hospital. We would expect that primary care physicians follow their patients when they're admitted to hospice and that they see their patients twice a week. If this is impossible, then the palliative care physician may take over their care and care for them in the hospice until their end of life. The other thing for emotional support, and this can be emotional support either for the patient themselves, or it can be emotional support for the family, as well as moving into bereavement support, is referral to the Cowichan Valley Hospice Society. So home and community care nursing can do this, as well as the physicians can do this. Your EMR may have a referral to the Cowichan Valley Hospice Society for emotional support. And an emotional support worker will go into the patient's home if necessary, or the patients can meet them at the hospice facilities. The hospice society facilities are in Gibbons Road, and they provide therapeutic touch and Reiki therapy as well there through volunteer services. Another service is an online service, and it is a program of group support for patients with serious life-limiting illnesses. So you can refer patients to this, especially patients who are really grappling with the fact that they do have life-limiting illness and they are suffering from what we call existential distress or disconnection or feeling that life has no meaning. So anybody with metastatic cancer, end-stage disease of the kidneys, the lungs, the heart, and any neurological diseases are welcome to participate in these programs, and they are free and paid under MSP. So you may refer them through the website, as well as there's lots of patient resources on the website. So patients who are struggling with nausea, appetite, shortness of breath, energy, constipation, incontinence, there are lots of resources on the website, as well as how to plan financially for end of life, as well as advanced care planning. So these resources could also be really helpful for primary care physicians as well. So you're also invited to access these resources. Any questions, please feel free to reach out to me. My email is Valerie, VALORIE.Masuda, MASUDA, @islandhealth.ca. And you can also reach me at 250-818-2119. Thank you and good luck.